Hello staff of Surgical ICU, it's Brenda, and today we're going to be sharing a little tutorial regarding data sets. During the presentation we're going to be talking about health information management, data sets, databases, and data mining, giving some examples of each so that we can use these elements in our day-to-day practice in order to impact patient outcome. So just a definition regarding health information management: the practice of acquiring, analyzing, and protecting digital and traditional medical information vital to providing quality patient care. Data sets are a collection of related sets of information, and they can be represented in table form. They're composed of separate elements, but can be used electronically and processed in order to answer questions. Databases are a way of organizing and collecting that data, and so that it's easily accessed for retrieval, managed, and updated by a computer. You can see from my representation here all of those paper charts that we used to have so much for healthcare now being all stored and protected in these databases. We can talk about how far we've come in terms of medical records and how important they are to the care of patients. The earliest history of health information management, including the recording of symptoms, complaints, and treatments of patients, even the ancient Greeks documenting and recording the symptoms, complaints, and treatments of patients in order to share and provide medical advice. Written reports from the 16th century describe complaints of patients and included diagnoses. Careful documentation of observations and treatments emerged as a way to teach other healthcare professionals right up until the 1920s, when the American College of Surgeons began to standardize medical records. These records continued to be paper-based, though, right through the 1960s, when the computer emerged as a way to electronically store patient data for larger organizations capable of supporting such technology. The field of health informatics was born when computer technologies became capable of managing large amounts of data. Nurses began to be required to collect data to document care for reimbursement with the introduction of Medicare and Medicaid in the 1960s. As healthcare technology continued to grow and standardize, resistance to share information and collaborate across disciplines was met through the 1980s. During the 1990s, as health systems began to emerge, the need for integration was recognized as the technology advanced and computer systems could share information across systems. With the presidential call for computerized health records in 2004 and legislative acts supported by financial incentives, the adoption of electronic health records, interoperability, and cloud computing further expanded networks of information to go beyond specific sites to encompass all health data and information. Value-based care in the 2010s and the need to improve patient outcome now drive healthcare professionals to use the growing body of data to guide clinical, administrative, and research decision-making. So data sets that were introduced back in the 1970s by the American Nurses Association can be still used today. The two that were recognized were the Nurse Minimum Data Set and the Nurse Management Minimum Data Set. And we'll go into some specific examples of these two sets. Nurses also have access to larger multiple databases which are available readily, such as the National Database of Nursing Quality, the NDNQI, and the Agency for Healthcare Research and Quality, AHRQ. And these are just two examples of the databases that are available to nurses at their fingertips and can be used at will. The NMDS, which we just talked about, is a framework for collecting nursing care data to measure quality of care, and they include such elements as patient demographics, nursing process data, including assessment, diagnosis, intervention, and outcomes, and also service information such as the agency that the patient is in, and admission and discharge details and dates. The NMMDS, which focuses on administrative analysis, is used for decision-making for nurse leaders, which would include elements as nursing environment, nursing resources, and finance. The use of data sets and databases allows nurses to store, retrieve, and use inpatient care to improve professional self-development, to use in collaboration with patients and their families, other nurses, doctors, hospitals, and entire health systems. Every day, nurses assess the health status of their patients and can record their impressions for their own use of interventions through data sets and be able to share them with colleagues who care for the same population of patients. So just how can we put this into practice? I did find a study that was done just last month in January 2018 in the Australian Critical Care Journal. And that study aimed to identify key items to include in a minimum data set for intensive care nurses in their shift-to-shift handoff. So they essentially created their own data set. The nurses always rely on informative handoffs to maintain continuity of care. While there are a lot of resources available for clinicians to assist with the handoff process, these nurses were finding there was a limited amount of resources that were available to them to be applied in the ICU setting. So they involved nurses in order to increase the likelihood of creating a tool that would be accepted and used. And what they did was they formed focus groups and conducted these focus groups in order to generate and prioritize minimum data set items. Nurses were presented with content from previous handoffs and asked to select which content items would be most important for a minimum data set. Participation response was summarized as frequencies and percentages, and you can see this data set example that they came up with. The data set was using the format of the ISBAR identification, situation, assessment also in there, background and recommendation. And specific items were proposed for inclusion in all clinical handoffs, while other items were considered only necessary to discuss if relevant to that patient. So these nurses were able to come together and make their own data set and create a tool for safe patient handoff. The increasingly complex and rapidly changing healthcare market that we are all experiencing today has also created new challenges for the delivery of health services. Healthcare databases allow administrators to examine and analyze large amounts of information in order to extract patterns and knowledge in the process known as data mining. Clinical data can be accessed from databases and used for research purposes in a more expedited form since the data is de-identified. Clinical databases facilitate healthcare research by aggregating records across institutions. These datasets track the progression of health status according to treatment and can be used to efficiently communicate findings to healthcare providers. Outside of the research context, electronic health-related data sets contribute to improvement in quality care by coordination, linkage, and retrieval of data, the coding of data in order for a standard language to be used as necessary. There's improved accuracy of documentation and informed decision-making. So because of this, more attention is being given to the development and broad applications of electronic health record data sets worldwide. The United States subsidizes the creation of national electronic databases that aid in quality improvement and informed decision-making under the HITECH Act. Nurses can also tap into the power of many large databases that are available today, such as the NDNQI, just to give it as an example. And you'll recall that in our institution, we do contribute to the NDNQI database through our quarterly prevalence studies for pressure ulcer prevention. But there is more to it than that, and that we can be made aware of. Being founded by the American Nursing Association and partnered with Press Ganey to promote nursing quality and excellence through benchmarking data, engagement tools, and advanced analytics. It's a source of comparative norms in healthcare and supports nurse retention through its RN survey tool. Used by over 2,000 hospitals nationwide, and it's the largest provider of unit-level performance data to hospitals and enabling hospitals to compare measures for their nursing quality against national, regional, and state norms for hospitals of the same type, and all the way down to the unit level, as we just mentioned. The unit level focus of the NDNQI RN surveys enable hospitals to develop more effective, finely targeted improvements, and also helps hospitals understand the relationship between the nurse-sensitive quality indicators, staffing data, and RN survey data. You can visit NDNQI at ndnqi.org, where there's a multiple of resources there And as I said, it's just a large database that's going to help hospitals across the U.S. and across the world to track and improve care by linking nurse-sensitive outcomes to quality measures. In conclusion, within healthcare, the systematic collection of nursing data is essential in order to make visible what nurses do and to facilitate comparison, quality assurance, management, research, and funding of nursing care. To be effective, nursing records should accurately and comprehensively document all required information to support safe and high-quality care of care of patients. Databases record the nurse-driven documentation and observation of patients, contributing to nursing knowledge and enabling nurses to make decisions based on best practice, thereby contributing to positive patient outcomes. That's all that I have for now. Thank you for listening, and please let me know if you have any questions.